Are you one of the millions with a health condition that requires you to use needles? If so, please listen. Disposing of your needles properly is a big responsibility. Accidental needle sticks in the home can injure family members, children, and even your pets. I am Dr. Drew Pinsky, and I have an easy solution for the safe disposal of needles and the end to accidental needle stick injuries. You may have heard about Sand Mini. The Sand Mini is the affordable, foolproof way to dispose of needles. It's FDA approved, and with Sand Mini, it is easy. Just insert the needle, press the button, and in seconds, the needle is incinerated. Now you have a needle that is completely safe to discard. No sharp points, no bacteria, germs, or pathogens. Make sure your home and business is sand safe. Every needle, every time. Go online right now and use our special promo code DREW2020 for our best offer ever on the Sand Mini. That's nomoresharps.com, and remember, use my promo code DREW2020 for our special offer.
Hey everyone, it's a dose of Dr. Drew.
Hey everybody, welcome. Thanks so much for stopping by. We're watching the chat over here at the Restream, so I appreciate you guys piling in. We'll give you a second to do so. My guest today is Dr. Marvin Seppala. He's Chief Medical Officer at Hazelden Betty Ford, Adjunct Assistant Professor at Hazelden Betty Ford Graduate School of Addiction Studies. Several books, including Clinician's Guide to the 12-Step Principles, and one I worked on with him called When Painkillers Become Dangerous. Also, Prescription Painkillers, History, Pharmacology, and Treatment in 2010. That was published. Dr. Seppala, thank you so much for joining us.
I'm glad to be here.
Susan, I'm already confused. Which camera am I looking at?
The big one, but
the far one.
It figures
okay.
The phone would ring right as we get. Oh,
okay, excellent. So the main reason, Dr. Seppala, we're here today, well, we got a million things to talk about, of course. And thank you for all the work at Betty Ford and Hazelden and all the organizations that Hazelden has acquired or associated themselves with. I always know I can rely. These days, being able to refer somebody to quality treatment is a very nefarious process. And as long as Hazelden is there, I know I can at least send them to Hazelden programs and things will be good.
Well, thanks a lot. I believe the same.
Yeah. So we are in the middle of this quarantine pandemic. The opioid crisis has raged on, and predictably, diseases of despair have gone up, and predictably, addiction has progressed as it does. One of the things that I've been frustrating me in recent years is how people miss the fact that addiction it's particularly opiate addiction we're going to talk about, is a progressive disorder that ends in death very often. And the fact is that this quarantine and all the focus on COVID has allowed the opioid epidemic, which we were sort of slowly starting to make some progress on, to spiral yet again. Where are we at with it?
Yeah, we were making some progress, and it was getting kind of exciting from our perspective. It looked like increased federal money, a lot of things happening, increased access to treatment, a lot more attention nationally, and partial recognition that this is a disease even that needed to be addressed, and now it's just kind of ignored. There's a huge increase in drug overdoses and associated deaths. The data comes from an unusual source, an overdose detection mapping app, and suggests that in March we were up 18%, 29%, or 29% in April, 42% in May. So,
oh my God.
Yeah, it's really worsening, and some local Minnesota data shows that it's worsening there as well. So we're in another real opioid crisis.
I've noticed also, I don't know if you've seen this, but this is not our specific topic, but alcohol seems to be way up as well, and alcohol-related illnesses.
Yes, absolutely. In fact, our front end people, the people who take the initial phone calls from patients and family as they're seeking treatment, have told me that the despair associated with these calls has quadrupled since the pandemic has started. People are desperate in a way they hadn't seen for some time.
I'm writing the words down because they ring so true to me, desperate and despair. And, our government has been making decisions as though they were clinicians. And the one thing that we all know as clinicians, that there's always a risk-reward analysis you have to do. And there's simply nothing we do as physicians or clinicians that don't have untoward, unintended, deleterious consequences, including just walk into my office. I mean, iatrogenesis is, we're all acutely aware of that, but we're so highly trained on do no harm and thinking of these risk reward kinds of phenomenon all the time. And our government is just, elected officials have zero experience with this. And so to try to raise awareness now of the unintended consequence of the total focus on COVID is not getting much traction in my experience. Not only overdose, suicide, depression, alcoholism, as we've mentioned, and then a fifth problem, which is that people have been delaying treatment for other medical conditions. The incidence of stroke and detection of heart disease is down 20% in the last 2 months. Well, it's not as though stroke and heart disease have gone away. It's that they are coming in sicker because people aren't coming in for detection the way they should because they're afraid, because they're avoiding hospitals.
They are. They're avoiding hospitals. They're avoiding regular medical care, regular follow-up. Some people are, with the unemployment rate as high as it is, people are divvying out their medications, trying to get by on half doses, whatever. All kinds of problems. And the same's true in the addiction field. People are trying to put off treatment. People always try to put off addiction treatment, right? That's not unusual. But now they have what seems to be a real legitimate reason for it.
Right. I'm watching a chat thread here, and there's some questions coming in for you. And this is a interesting, a reasonable one to frame some of our conversation. Let's give them a little primer on the demographics of opiate addiction, who gets hooked, and are the predisposing phenomena.
Yeah, the primary risk factor or predisposing phenomenon for opioid use disorder or any of the addictions is genetic, actually. So about 55% of the risk is associated with genetic predisposition. Then there's significant environmental risk factors, of course, and trauma would be high on the list. Anxiety is always described. It's hard to know what exactly that may mean, but under stress, people are more likely to use psychoactive substances, and if they have a genetic predisposition, they're more likely to become addicted to them.
Yeah, as I believe Mark Shuckett used to say, he used to frame it this way. He would say 60% of, he was very careful with how he selected his words on this, and he would always say 60% of addiction is accounted for on the basis of genetics alone.
Yeah. I've heard him say the same.
Yeah, and
done a lot of good research.
Oh yeah, and he had that. He was looking at alcoholism primarily through much of his career, and he had that cohort of sons of alcoholic fathers.
Yes.
And he did some really good studies on particular genes and genetic risk factors and what led to people getting alcoholism. And of course, alcoholism and addiction is sort of the same genetic pool.
They really are. It doesn't matter what drug or what intoxicant people use. If they have the genetic predisposition, they're just at higher risk. And maybe someday they'll be able to distinguish among them somehow genetically, but I'm not sure.
Not yet. And and then you mentioned trauma. So the two, particularly with opiate addiction, the two features are you have the genetic heritage, right? And then you have trauma, and trauma causes, loosely speaking, emotional dysregulation, where you can't regulate your emotions, and you start looking for solutions to that. You reach outside your body. People use food, sex, drugs, and if you have the genetic disposition and you get to drugs, now you get a second problem, which is addiction.
You sure do. And the addiction itself may actually initially with trauma help the individual. They may be able to avoid some of the intrusive thoughts, that sort of thing, reduce the anxiety, but addiction is a chronic illness. It just keeps getting worse. And if you're predisposed to it and go down that path, it's going to get really bad and ultimately undermine any benefit it might have provided initially.
Yeah, as most of my patients will say, the reason they use drugs is because they worked.
That's right.
You don't use drugs because they don't work. You use them because they do work. But then you get a second problem, and when they stop working, you can't stop, and then that's addiction.
It is. And interesting when you say that, the new sort of neurobiological understanding of addiction is not that it's positive reinforcement, that I like it, so I'm going to do it again. it's negative reinforcement, a relief of a painful stimuli. And that comes from when they quit working for the positive aspects of them. When you're just kind of going to work every day, trying to get enough money to get enough, heroin or fentanyl or whatever to inject and avoid withdrawal.
Somebody's asking, any of the meetings happening are we getting in-flesh meetings, 12-step meetings? Not in California. I don't know about some states. But there is some good news out on the 12-step front. John Kelly and Keith Humphreys got their Cochrane analysis published finally, although it was lost in the COVID thing. What are your thoughts on that?
Yeah, it's fantastic that they did it and pulled all that information together and published, because there was a prior Cochrane study that kind of suggested that 12-step programs were not beneficial or no better than anything else. And they proved that's, these 12-step programs are very effective and worthwhile. It's certainly not for everybody. Our program's actually based on them. And we do a lot of other things. We provide mental health services, individual group psychotherapy. We don't expect people to pay for 12-step programs in treatment. We do a lot of other things.
Well, but the converse is true. This is an effective treatment. Kelly published a Cochrane analysis that shows it is as good as professionally managed care, and sometimes better when abstinence is your goal. And it's available everywhere, and it is free.
It is.
I mean, you talk about the cost of healthcare. Here is a free, effective intervention available on everywhere. And why people would attack that is the most bizarre thing in the world to me.
It is to me as well. If you had to design a system to address a chronic disease, how could you beat free, available almost everywhere,
right,
with all kinds of support? You can call someone 24/7. They'll actually usually answer and try and help you. That's pretty hard to beat.
Crazy. It's crazy. And by the way, there's even another sort of layer to it, which is that early in treatment, addicts need so much attention and structure that there just aren't enough. There isn't enough money to put professionals on top of that. You just couldn't do it. Just not practical. But because somebody did that for them when they were needing it, they're willing to do it for other people, and it's a huge workforce that does untold amount of good.
It truly is, and they're ready and willing to do it, which is really amazing. The 12th step, the last of those steps itself, suggests that that's what they should be doing too. Yep. And helping someone else actually helps oneself. Not something they invented, but extremely useful.
Jason says, if I told them they had cancer, they'd seek any treatment you recommend. That is absolutely true. This is the thing about addiction. It's the one disease you have to convince people they have and convince them to listen to you for the treatment, because they have other ideas always. It's really true. When you look at the data about who seeks treatment in the United States, only about 15, maybe 20% of people seek treatment, and the vast majority that don't know they have this disease. Right. And that's the issue. We have a public health problem that people don't understand and have little knowledge about. Let's drill in on the opioid crisis a little bit. What in this epidemic, what are your recommendations? What should people be doing? In the midst of this, the problem for folks with an opioid use disorder right now is that addiction is a disease of isolation. And so you're happiest, especially using opioids, you're usually happiest by yourself, right? So it just kind of gets into this vicious cycle, and it's hard to break out. You don't want to be around other people because of the things you've done to them. Maybe you've ripped off your whole family, whatever. You're doing, illegal acts to get enough money to keep using, or you're just ashamed to the point that you don't want to be around anybody. Right. And the truth is, it's being with people that's going to help with the healing. And that's part of the issue with this pandemic. It doesn't allow folks to meet together. One of the most important things, I think, to getting into recovery. And yet, some treatment centers are open. Our residential programs are open. We're testing people for COVID prior to admission to try and keep them safe. Nonetheless, most treatment on an outpatient basis, most AA meetings and other support services are done virtually now, which are essential.
under the circumstances that don't quite have everything necessary.
If somebody has an opioid use disorder, I know this is almost an unfair question because every case is so different. Help them understand sort of what's out there for them, because a lot of people are afraid to come in for treatments and they're afraid to go anywhere. And I guess what I'm tilting at is I know there's a big movement towards in-home and outpatient kinds of services, particularly as it pertains to medication-assisted treatment, which is a big and nefarious kind of topic, but I'll let you kind of back into it.
So, I think people should have access to whatever kind of treatment they need, and a good evaluation is the place to start. You can argue, well, an opioid use disorder, they're obvious, people just need treatment. Not necessarily true. They could be, they could describe it in a different way. Maybe they're using multiple substances. It's just part of the picture, that sort of thing. But getting a good evaluation, whether it's by phone, by video, or face-to-face, and getting information from a professional about what to do about your disease, just like any other. And if you need residential treatment and they recommend it, pursue that. If they say, hey, you could probably get by in a virtual outpatient setting right now, then do that. But folks with opioid use disorders, we use a combination of treatments. We use a 12-step orientation. We provide the medications, buprenorphine or naltrexone for opioid use disorders. We want people to stay engaged really long term. And that's one of the things about opioid use disorders is that they are long lasting. The craving goes on for 6, 12, 18 months. It just lasts. And it's the chronic nature of that craving that trips people up over time. It's real easy to think you're doing great. A lot of good things are happening, and suddenly, bam, you're right back where you started.
Well, and it's funny, and there's been a lot of focus on craving in the last 5 years I've seen in the medical literature, and I always felt the craving was a good thing.
Absolutely.
Yeah, because craving is a conscious experience of your disease. It lets you know it's active, it's well, you need to go to meetings.
Yeah.
It's the people who aren't aware of the motivational distortion they're in that start having distorted thoughts that end up using. They start thinking, no, I need to go see Susie. And I will go like, Susie? You haven't seen? Yep, that's somebody you used to use with. Oh, yeah. But no, she's a dear friend. I haven't seen her in a long time. And it's been 6 months and she's clean now too. I know it for sure. All this nonsense. And that's all. And they believe it. They believe it because their brain is going, yes, go that direction. That is not a conscious craving. That is a motivational disturbance we call addiction, causing something we call stinking thinking, moving somebody back towards using.
It sure is. And it's driven, by a reprioritization of drive states in the reward center of the brain where all of our rewarding behaviors, things that make us feel good, occur. Things that keep us alive. Survival itself comes out of the reward center.
Exactly.
And once addicted, it reprioritizes that to be the most important thing. So people in the midst of addiction risk their life without even thinking of that. It doesn't even bother them because there's something more important that they're pursuing subconsciously, not really truly recognizing.
Yeah, that's exactly right. And that's what's so interesting about the disease, to see the brain operating under a circumstance of distorted motivations and how all the other systems misfire in response to that. It's very interesting. It's very intriguing as a observer. It's no fun as a patient.
No.
One of the things that kind of disturbed me is, I got my X waiver for buprenorphine prescribing. I originally got into addiction treatment to be able to bring abstinence. I was interested in abstinence-based treatment. That's all I was interested in. I'm not saying that's what everyone has to do. That was my that's my expertise, is bringing people through. And so I was always reluctant to use any sort of opioid replacement therapies on my unit. But I understand that the disease has progressed in terms of its demographics, and we have to use everything we got. But so I'm certainly open to using buprenorphine and carefully managed, and other treatments kind of brought in with it and whatnot. But I was struck I'm a naltrexone fan of all types. Whether it's injectable or implants or whatever. I just think naltrexone, to me, the data looks really, really good on it, and it certainly works, and it helps my patients stay abstinent and all these things. During my symposium for the X waiver, they of course review all the medication-associated treatments, and they bring up naltrexone, and they go, "Oh yeah, naltrexone's excellent. It's very good, but 40% of the patients are lost to follow-up in our studies. Therefore, it's a bad medicine." And I thought to myself, "Oh no! You don't know how to run a program where you hold your patients." And of course, they're good. The ones that are on naltrexone are the ones that are risk to run away from you. You have to run a better program that keeps them engaged. Yeah. And so I was really disturbed by that because I don't have that problem with naltrexone. I do keep my patients engaged in the process, and then naltrexone helps them not get high.
It's interesting because if you had to invent a medicine for opioid use disorder, you'd invent naltrexone. It blocks intoxication, right?
Exactly right.
It's almost perfect. It doesn't cause intoxication. It blocks the intoxication. Right. It's safe, effective, pretty remarkable medication. And we're biased toward it as well because of all those reasons. And it's a great medication. You're absolutely right. If your program isn't structured in a way to keep people coming back to maintain engagement and get the next injection or the next prescription or whatever, that's yours. That's on you.
That's right. That's right. I was a little surprised that went off as something that all these newbies to the whole field of opiate addiction and wanting to get involved in it, or hearing somebody say that, I'm thinking, oh my God, that's not how we do it in the real world. But anyway, that's one of my concerns as we've created the armies of doctors that can prescribe buprenorphine that humbly are not sophisticated in their clinical prescribing or clinical experience with these patients. I mean, you and I mean, how many figure opiate addicts have you treated in your travels?
Not even sure. Tens of thousands.
Yeah,
I don't know.
Right. Thousands. Me too. Thousands. Yeah. And you probably also lived through what I did as well, which was the oral opioid and oral benzo opioid combo catastrophe that we went through in the 90s and early 2000s.
Absolutely.
Which is one of the most frustrating experiences of my life. And now I'm worried that we've actually, again, in an unsophisticated way, gone too far where pain patients now can't get their opiates. And people don't understand the difference between giving a pain patient with addiction oral opiates and benzodiazepine combinations without managing their addiction versus a straight up pain patient that needs chronic opiates. These are different things.
It is totally different. And it's just a huge quandary now. I'm involved with the pain folks at Mayo Clinic and do some speaking at their annual meeting for physicians that are not pain experts, and it's the same sort of repeated refrain. Basically, some people need opiates, some people really are in danger with opiates, and even some of those need opiates.
Right, that's right. But the average pain physician, see, I would trust you with making those calls because you have a deep understanding of addiction. The pain folks that I deal with, for the most part, not all, there's some good ones out there, are in denial about the disease of addiction generally, let alone not sophisticated about acknowledging or identifying it.
I actually spoke at a pain conference, national pain conference. It's probably 8-9 years ago now, and I gave a fairly strong description of the problems going on with pain and addiction. And the speaker right after me got up and he was right out of the book supporting the use of opioids for everybody with pain, independent of addiction, that it wasn't a big problem. It was right before a lot of media attention to this crisis, and of course, once I sat down, I had no recourse to talk to.
Terrible. If anybody wants a good book that really chronicles how this evolved, read the book Dreamland by, right?
Yeah.
Let's also plug your books.
Okay, hold
Dr.
on.
Seppala.
Hang on. But I'm forgetting the name of the author. I've shared the podium with him a number of times, and he's been on
Dreamland.
Quinones.
Yes.
Quinones. Yeah.
Sam
Quinones, who lives like right down the street.
He has a hard
here.
name like you.
Yeah, and he and I last were in Florida together, and man, the guy really did his homework. He understands what happened there. And we still have a residual from that whole time, which is continued benzodiazepine overprescribing.
We sure do. And as the data started coming in from the opioid overdoses, you could watch the benzo overdoses go right up with them because it was mostly people using both, right?
Yep.
And then we started to address the opioid overdoses without addressing the benzo overdoses.
That's right.
And I suspect it'll be the next crisis.
I hope. We got meth too on the rise too.
We do.
Big time. The books are Clinician's Guide to 12-Step Principles, also When Painkillers Become Dangerous, and Prescription Painkillers History, Pharmacology and Treatment. There they all are.
Mm-hmm. The Clinician's Guide, is it a white cover like that, or is it just?
It's actually out of print.
That's why. That's
no
why
longer available.
Oh, is that why? Well, anyways, he wrote it. He's written 4 books, one of which he wrote with Drew Pinsky, MD.
Yep, there we are.
Yeah.
That was a fun little one. And it's interesting that we wrote that book probably 15 years ago, right? I mean, we were all concerned because we saw what was happening.
Exactly.
And it came, here it is.
And even the book on the history pharmacology stuff, it was only about 10 years ago, and it was still too early. No one paid any attention to those books.
It was really...
So is the most recent one the pain-free, drug-free book? Is that the most recent one?
No, the history and pharmacology is that pain-free, drug-free was written for folks in recovery who wanted to address pain, chronic pain in particular. I wrote it with a pain expert from Mayo Clinic.
The more recent one is down there just underneath it.
Prescription Painkillers.
Yeah. History, Pharmacology and Treatment.
That one's Kindle price is $9.99. The one above it is $31 for paperback, and I'm not sure why, but
weird.
Check it out on Amazon.
It is weird.
Here's a great question. Di asked, can Suboxone be prescribed for chronic pain management instead of opioids? Let's just say Suboxone is an opiate, for the record, opioid. And yes, it can be. And it's being prescribed more and more and more and with greater efficacy all the time. Would you agree?
Absolutely. Yeah. You can't prescribe the type that's used for the treatment of an opioid use disorder. You have to use a different type of Suboxone, but it's the same basic medication and it works very good for chronic pain. And there's a ceiling effect. You keep taking more, you don't get intoxicated after a certain point, which is good news.
What was the other thing I was going to mention about? That's an aging brain. Lost my train of thought. Is there anything in particular you want a messaging you want out about our current circumstance in the middle of the COVID, and if people are struggling with addiction, what are your sort of basic recommendations or places people should go? Say go to the Hazelden website.
That's the best. Go straight to the Hazelden website. I mean, I think the main issue is this is a stigmatized illness. People have a great bias about addiction, and under the circumstances, it's just even harder for those people in need to access the care that they need. And so be kind to them, try and help them out. It's a very difficult disease, and people with it don't really truly recognize what's going on.
Young Rudy asked if we talked about Jordan Peterson's experience with benzodiazepines. We have not. I am mortified by the treatment he got. I've heard his daughter and he chronicle the whole story, and it was an absolute catastrophe that didn't need to happen. I'm sure, Dr. Seppala, you have dealt with many, many opiate addicts with akathisia and other sorts of complex withdrawal syndromes, and we know how to manage that. Why they didn't go to you or me, or it literally in a month we could have had him straightened out. Instead, he's had a year of just catastrophe, including aspiration pneumonias and ventilators, and just when I hear the story, I want to scream, and it's just awful. But thankfully, he's doing a lot better now, from what I understand.
Good.
Yeah. Let's talk about benzos because you see a lot more of stuff we never used to see. I've seen a little bit more of lately. Are these sort of unusual withdrawal characteristics where people have extreme sensitivity to getting off this medication? I've had people unable to get off, an eighth of a milligram of Klonopin and just go into this akathisia when they try to get off. What are you doing for people like that these days?
What we've had to do for, especially for high dose long-term benzodiazepine use, we've had to go to long, slow tapers to try to prevent that sort of thing, which doesn't lend itself to a distinct sort of period of treatment. It requires, really adjustment and even for some people, several months of use
Yeah.
of the benzos, which is difficult. You really want to have a structured situation, somebody else that's really engaged with them
Yep.
to help out. But that can prevent that sort of thing.
It's miserable. It's dangerous. The cavalier attitude we have about sustained benzos has greatly concerned me for some time. We've talked about meth. Any thoughts on that?
Boy, it's it's coming back absolutely, and in the Midwest, especially with all the ammonia sitting around in farmers' fields, it's commonplace to find it being developed again.
Oh, that's interesting.
And it's without any medications that could make a difference, unlike the opioid use disorders. So we're left with abstinence, which works for a lot of people. But when people are using meth and they're psychotic because they haven't slept for days or they're prone to psychosis, they can be very difficult to engage in treatment. You really have to get a point of stabilization to even get them into a treatment program often.
Well, that kind of dovetails into the homeless conversation. The homelessness out here. I don't know if you're aware. Are you in Minnesota? Or are you out here?
I live in Portland, Oregon, but I work out of Minnesota.
Do you are you involved with Springbrook at all?
Yeah. So Springbrook is now we call it Hazelden Newburgh. It's part of our system.
Because I've been referring people to Springbrook. Newburgh?
Yeah.
Uh-oh.
If you gave them Springbrook, they'd probably find it anyway. But we call it Hazelden Newburgh.
Newberg?
Yes.
Okay, good. Thank you for telling me that, because I've sent a lot of people up there over the years, and
oh, great.
Really appreciate the treatment. In California, we have laws that make essentially drug use legal, drug trafficking legal, stealing to support your habit legal. So guess what? Dr. Seppala is my patients. Head on out here. They're coming, man. You give them that environment, they is coming. But the laws are making it such that it's impossible to reach people that have deteriorated with their addiction to the point they are on the streets. Do you have any thoughts about what we should be doing for these populations?
I'm actually on the board of a group here in downtown Portland called Central City Concern. And it's a housing first addiction treatment program for the homeless that are in the inner city of Portland. And it is a very effective program, been around since the early 70s. Now we have over 2,500 apartments for the homeless, in addition to multiple treatment programs, residential, outpatient, ongoing support, mental health, and medical as well. And that is a very good way of doing it. But often people need intervention, especially when they're at that level, when you've lost everything. You are homeless, you're familyless, no more job, no more anything. You need other people to take a hold and do something. And sometimes that requires a legal intervention as well.
Well, in California, we're prevented from doing any of that. Prevented. And people are dying at a rate of about 3 a day in our streets. But I know you said you have 2,500 that Central City Concern have dealt with. We have 80,000 we need to deal with.
Exactly, that's the problem.
I just realized I wish we would stop calling it homelessness, because it suggests that if you give them a home, you've solved the problem. And nothing could be further from the truth. We need residential psychiatric care and chemical dependency treatment. Period. End. Residential, yes. Home, no. And so I'm very concerned about the situation we're in California particularly.
It's a huge problem around the country, but especially on the West Coast. All the major cities up and down the coast have the same problem. And you saw all the things going on in Seattle. It's just gotten out of control, and the same thing going on here in Portland. And we need solutions. And it's a very complex problem. I certainly don't know the entirety of it, but a great deal of it is caused by mental health issues and addiction.
course. Well, the vast majority. And again, with the laws the way they are here, our patients are, of course they're coming. Of course they're going to come here. And the part that people miss, I said this at the opening of our discussion, is this isn't a static situation. It's not, oh, let them use their drugs, it's fine. It's a progressive disease that ends in death, period, end. And if you are not intervening, you are killing, period. And I'm mortified by what we've got going on. I can't stand it.
If you can intervene in other ways, you should. But if you can't and it continues, then you have to use it. The means that require legal action. We can hospitalize somebody. When someone attempts suicide and remains suicidal, we can hospitalize them against their will. But in many states, we can't do that for folks that are overdosing on a regular basis.
That's right.
Being revived by personnel out in the field or in a hospital setting. And we can't do anything about it. They can just walk right back out. At that point, they are going to go use opioids because that's what they need.
That's what they do. They must do that. And they will not stop because they're having consequences. That's the nature of the illness, is you don't stop despite the consequences.
Mm-hmm.
Well, listen, Dr. Seppala, I appreciate you being here, and I appreciate everything you're doing. Is there anything else you want to tell people as it pertains to our unique circumstances presently before I let you go?
Boy, I would say, seek the help you need. Get on the virtual meetings. Do whatever you can to engage with other people somehow. If you're trying to get sober, trying to stay sober. We've noticed some of our people with opioid use disorder that have got a few weeks in and are starting to do well, suddenly having great difficulty in these virtual settings, even with our own virtual intensive outpatient program. So it's a lot harder than it may seem.
And there are medication-assisted treatments if you were stuck home. There are a lot of physicians out there can help. I say start the Hazelden. If it's a Hazelden program, you can pretty much rely on the quality. That's what I always tell people. They're like, where should I go? If you got a Hazelden program nearby, you're in pretty good shape.
Well, I certainly agree. I've been actually went to treatment there at 17 after dropping out of high school. Now I help run the place.
No kidding. Congratulations. That's a big deal.
Thanks a lot.
Yeah.
I meant to post all the links to NA groups, Recovery Go, the Daily Pledge. That's one that I was sent. AA Online and the Hazelden app.
Good. That's all. You're going to put all that up there.
I'm going to put it there again. So if anybody wants to spread the word, that's. I've been asked before where to go, so that's what.
Let's go write another book about the history of. You and I have two books in us. One is the history of the opiate thing and how it's preventing people from getting adequate pain management right now, and also and then maybe dovetail into the benzo concerns we have.
You're right.
I did have another question for you. Somebody was asking about. Ibogaine, those forms of therapy. Any thoughts about those things? There's a lot of that chatter here I saw on the chat. The hallucinogenic therapies.
Yeah, I think they're not adequately studied yet for general use.
Right.
Maybe there's something there that we could learn from, but there's also a great deal of problems associated with that stuff. People remaining psychotic, having intermittent problems like that.
That's right. That's been my experience too. And even in those, I've seen one case of sustained abstinence, somebody went down and used that stuff. In every other case I've seen, they spend about 6 months indeed they don't want to use for about 6 months, talking about the importance of the experience they had, and then at 6 months start using again. That's been my experience.
I haven't had a lot of experience with the folks, but the people I have seen were all seeing me because they were using again.
Right, exactly. There's no easy fix. It's a complicated illness, requires multiple different facets and interventions, and it's a chronic illness, so you have to be working on it every day.
Sure do.
All right, Dr. Seppala, thank you so much. Do you have your own website we should refer to?
I don't. It's just hazeldenbettyford.org.
So we should do a book on the opiate thing as it pertains to the benzos and the inability to get pain medication.
Buy his book.
We should do another one on 12-step and how 12-step has been under attack, and how to see it through to its present glory. It's easy, it works, it's free. It's not.
Yeah, the one on 12 steps was available on Amazon. I don't know why.
What?
But it was just a blank picture. Hey. I guess. I don't know. I didn't really look that closely.
All right, sir. Thank you so much for joining me.
Well, thanks for having me. I really appreciate it.
Hopefully we'll see each other soon. Thank you.
Good deal. Take care.
You too. And I'm going to do a little COVID review here for guys that are still on my chat. So let me give you some thoughts on where we are at. Where we are at, it is confusing, I would say, that you have a lot of states. Yeah, Andrew, I saw this. Dr. Zelenko made a very dramatic statement today, and Andrew, thank you for pointing this out. In an interview, he said he believes so much in his prophylactic treatment of hydroxychloroquine and zinc that he does not wear a mask when he is seeing COVID patients. So that's a pretty interesting challenge test in Dr. Zelenko himself to see if he contracts COVID. So keep an eye on that. And Andrew, please keep an eye on him to see if he tells us if he does get COVID. That'd be very interesting to see, or how long it takes him to get it. Personally, I take the zinc, and I would take the hydroxychloroquine if I got sick. So the issue on the COVID right now is that things are confusing, I would say. Now, predictably, we've seen an increase in cases, right? People are moving about, people are congregating in the streets. If you see an increase in cases, you see an increase in hospitalizations. If you see an increase in hospitalizations, you're going to see an increase in deaths. All happening, all not a big surprise. The question, what's confusing right now, is we've gone from roughly 20,000 cases per day in the country to 60,000 cases. The question is, are we going to have an exponential burst here where we go to 180,000? Is that what's going to happen? Or are we going to really get serious about wearing masks and physical distancing and get this thing under control again? I certainly hope the latter, but I don't know. It's a kind of confusing. We'll have to see where we go over the next 2 to 3 weeks. The head of the CDC today said that we could have this thing under control if we wore masks universally. And I agree with him. Nippo says Dr. Zelenko mentioned zinc sulfate with quercetin. Anything careful? I don't know about the other zinc preparations. That's an interesting question, like a zinc gluconate. I don't know that. What he did, Ninpo 1500. What he told me was 50 milligrams of 50 milligrams of elemental zinc, if I remember it was his recommendation. So however you get the elemental zinc, that's how you do it. Let's see. Yeah, so what if in March they would just have told everyone to wear masks? We would be in better shape, right? They did not know the masks were as effective as they are. They had not yet reached a consensus. That's the way the medical clinical practice works. It takes us a while to reach consensus on things. And once we do, usually we come to the right place. And I'd say we're there now. I know there are people out there saying we do not need to wear masks, but I think that's a grave error based on the data that I've seen repeatedly. So I think it's a grave error to discourage mask use, and a not a smart place to draw the line. Not a smart pace. JH, the zinc quercetin makes you feel a bit nauseous. Yes, it does. It's the zinc. The zinc does that. Kelly, I'm talking about the chronic pain I think you're asking about. And I talk about the fact that I am my thing is a sophisticated, rational approach to opiate use disorder and chronic pain. And we don't go to one extreme or the other. We don't pretend addiction doesn't exist. We don't treat dependent, non-addicted patients as though they're addicts. And we don't treat patients that need pain medication as bad patients. And we use everything in our armamentarium. I will tell you that there is extremely good use for chronic pain with buprenorphine. Buprenorphine looks really, really good for chronic pain now. And there's no reason you would not use it. Goro, I'm reading your question there. I'm not treating the Twitch audience differently than anybody else. I just see a scroll going by rather quickly, and I try to catch what I can.
It's a little purple one.
But Goro 187, I did not see anything except this comment that's scrolling by my face right now.
Pain-free to live free looks like a man with mental powers.
What?
The book Pain Free to Live Free looks like a man with mental powers.
Okay.
That's the Twitch guy.
Dustin, do I actually believe he said he's not wearing a mask while treating? Zelenko is a straight shooter. If he may be just attempting to do a challenge test on his own. Doctors have been known to do challenge tests throughout the history of medicine. So here he is doing a challenge test. A doctor will often put themselves in harm's way to prove them, to try to do some medical research. That has been happening forever. What's that, Susan?
I'm just looking at this kid on Twitch. He's probably like 19. Dr. Dr. Doom, a.k.a. Victor Von Doom of the real world.
That's his comment I'm supposed to read?
Yeah, he's like a gamer. See?
Okay, but he wants
That's
me to
what
read
Twitch
his.
is all about.
No, I understand that. How do you start an intervention, Stephen? You have to get an interventionist. You have to have somebody who knows how to do interventions. You have to rehearse it. You have to organize it. It has to be done. It's an ambush, and it has to be done with and by somebody who knows what they're doing. You do never try an intervention on your own. Do not try an intervention on your own. It does not work. Okay, so
it's nice to talk about addiction again.
yes, right. CBT for pain, yes, no problem there. That's an excellent thing if you can get some pain relief with that. Dr. Agus released a video about Moderna trial starting. They were both T-cell and antibody activity in the phase 1 trial. Yes, they have phase 1 and phase 2. Moderna, I want that Moderna vaccine now. I can't get it fast enough. I want to be on a phase 3 trial. So, yes, please count me in if anybody knows how to get on. I signed up at the CDC, I think it was, to be in phase 3 trials, and they're not contacting me. I would love to get that Moderna vaccine. My feeling is I suspect they're going to start offering it to like healthcare providers in November. That's what I bet happens. Dr. Oz interviewed a guy, a famous virologist and vaccine researcher, that said it's going to take a year before it's distributed. And I thought, yeah, that might be true, but it's going to be available before that, I bet, because the data just looks too good for them to hold on to it. And I understand he doesn't want there to be a reaction, because there's bound to be some negative effects, right? That any medical intervention, there are negative effects, and he doesn't want that to be, the ability to distribute, be impaired by people being afraid of it because of some single or couple of stories of adverse outcomes. Jason, elemental zinc, that's all I can tell you. He didn't specify what preparation that came with. My thoughts on criminalizing non-mask wearing. I worry about the government overreach on all these things. Generally, the overreach is just very disturbing. For instance, why are nail salons closed? Has there ever been a case? Has anybody ever documented COVID, a SARS being transmitted in a nail salon? Has that ever been documented? Why'd you close the nail salons? Just today, a study came out where two hairstylists, two hair cutters, were sick with the virus, exposed 139 people. I think this is in Florida. Look it up. 139 customers were exposed to two barbers who were actively secreting virus, and the transmission rate with mask wearing was 0. 0 transmission in spite of closeness, hair cutting, in an environment that has been shut down in California. 0 transmission, 139 exposures simply by wearing masks. Why did you shut down the salons? Why did you shut down the barbershops? These people need to make a living. Why did you shut them down? Here's clear evidence that it doesn't transmit if people do the proper thing. It's just insane to me. Mm-hmm. Oh, well. Yes, JH, it is a good case for masks, isn't it?
You're going to make people drink more.
I am? By doing what?
No, if you don't let them work. If you're shutting down businesses that are not causing the problem, it's just going to cause more mental health problems.
Help not really wanted? That sounds like you really do want help there. How did I get my heart right? Rebecca, I'm not sure what that is. Because my heart isn't right now. I feel like really disturbed all the time by the extreme porn, panic porn in the press, the way numbers are being reported such that I can't even can't even see what's really going on. So it's very disturbing. And then the government overreaching all over the place, doing things in the name of science that clearly do not have a scientific basis to them. Again, just look at the H1n1. It's time we did look back at some of the other epidemics. I'm not saying compare them. I'm saying take a look at how we approached the H1n1 epidemic in 2009, which killed 600,000 people. 575,000 people died from H1n1. Somewhere between 500 million and 1 billion people were infected, and you don't even know what happened. It was a story on the news at night, and the news essentially said doctors are concerned, doctors are struggling, they're opening tents outside the emergency rooms to keep them isolated. I got that virus. It was terrible. It was horrible, and it killed 20 to 40-year-olds primarily. You don't even know what happened. So why did we go through a 500 million people infected in 2009 that we didn't even make an issue of in the press? And now this one, we're making panic porn at all times. It really is quite extraordinary. So.
And then you're stuck together in a house with me all day.
Well, that I like.
Aw.
JH, yes, COVID deaths, I believe, have surpassed H1n1 deaths globally. That's true. This is not the same as H1n1. This is worse. Let's make no mistake about it. But I just think we should look at our emotional responses to what's going on and what we do with all the crazy press. When in 2009 we had a similar thing happen, you barely knew it happened, and now we're freaking out and destroying the economy and destroying people's lives. There's got to be a middle ground somewhere. There's got to be a middle ground. This one is more infectious. It is worse. No doubt about that. And it needs a more powerful response. But does it need the over-the-top response that we're giving it, or does it need some kind of intermediate, so where we don't create all the diseases of despair and the opioid addictions and the people overdosing and people refusing to come to the hospital to get their proper medical care? That's the concern. That's the concern right now. Masters of Blackjack, the teachers using demands before opening. Yes, and did you see the American Academy of Pediatrics is strongly recommending schools to open? Strongly recommending it. Oh, yes, I'll be on YMH tomorrow. Oh, boy. Matthew's, your mom's house tomorrow. I'll be on that with Tom Segura and Christina P. Yeah, it's an Let me just say they boiled the frog. They boiled the frog. I'm the frog. You'll figure out what I mean when you watch that.
I'm going to put up the Christina P. banner for 1 second today, just because it's kind of, it's, okay, just a quick one, just to promote.
Okay.
Okay, you ready? Just because it's got a really racy name. Okay, but check out the Dr. Drew After Dark show as well.
Werewolf says COVID is a multi-organ failure machine.
I'm trying not to get in trouble with you, too.
Yes, it is a multi-organ failure machine. If you are over 75, particularly over 80, you have hypertension, hypercholesterolemia, insulin resistance, and antiphospholipid syndrome. In that case, organ failure. Absolutely. If you are a 40-year-old or under, 0.3 to 0.8% fatality rate. No, doesn't cause organ failure in those people. So it's different age groups. That's what's kind of crazy about this disease. It's very different in different circumstances.
You're also going to be on Fox News tonight.
Fox News? Oh, Fox 11.
Fox 11. Sorry,
11.
Not Fox News.
Not
Sorry.
Fox News.
Oh, God. Kill me now.
Yeah. Okay.
But we have a show tomorrow with Tyrus, and I think we're going to get Kat Timp back in as well.
Oh, on tomorrow?
Yeah.
Oh, that's great.
Yeah.
Clara, antiphospholipid syndrome, you would have clotting tendencies, you'd have changes in your ProTime and your PTT. It's a specific syndrome, though a surrogate for that it would be obesity. Obesity is the other risk factor other than antiphospholipid syndrome that puts people at high risk for the organ failure phenomenon. And again, the organ failure caused by cytokine, caused by cytokine release syndrome or cytokine activation or cascade, however you want to call it. Okay, I think we're going to wrap things up. Susan, if that's okay with you. Any last minute stuff? I've got the headline here on my medical stuff. Hold on a second. Blood test could signal more severe COVID risk. What would that blood test be? Hold on. Let's see if I can find out what that is for you guys. That seems like breaking news. Low lymphocyte count in people. Hold on. Low lymphocyte count in people presenting to the hospital with COVID-19 could help identify those at higher risk. So lymphocytopenia appears to be a threefold increased risk for ICU. So there's something about, this is not going to be the average person getting a blood test. This is if you're coming in sick with COVID, if you have low lymphocyte count, that's a marker that you could get into trouble quickly. Now, what we do with that marker, kind of interesting, because again, we don't know quite what to do with you, whether we put somebody on dexamethasone or remdesivir or something like that right away. I don't know. Dustin, that was brand new breaking news right there. Lymphocytopenia is a marker. Why are you a boiled frog? Kelly Gallagher asks. Because Tom and Christina slowly enrolled me in their crazy world. And much like a boiled frog, I didn't feel it getting hot. And pretty soon I was being boiled. There you go.
And they called me too.
Yeah, did we call you during your mom's house this time? Okay. No. I think Tom and I called you.
Yeah, Tom. Oh,
that's different. No.
This is on the other show.
This is on your mom's house. Yes, that one should be up soon. Okay, let's kind of wrap things up. I'm kind of running out of steam here. Tomorrow is.
Hold on one second. Just
tomorrow
hold
is
on.
Wednesday, right?
Yes,
we'll have
hold on.
Christina. We'll have.
Hold on.
Let me describe what's happening tomorrow.
Okay, now you can say it. Oops.
We'll have Tyrus and Cat Timp. There we go.
off.
There they are. And they, of course, have their podcast,
I was just throwing that together.
Tyrus and Timp.
Sorry, it's a little messy, but I'm going to fix it before we go out. She'll be on tomorrow. She wants to know if you can help her make Carl an emotional dog.
Huh?
Probably.
Oh, she wants me to sign up paperwork for her?
So she can probably fly with him. I think the dog's been good for her. I mean, seriously, imagine being in this quarantine and being her. She's a
libertarian, though. She doesn't want comfort dogs and things like that.
Yeah, but she needs pets. She needs kids or pets, and I don't think kids is a good idea right now.
I would agree with that.
Just because they live in New York City. But she's very nice to come on the show. So.
CJ says LA County is trying to slide $2 million over to the LA Sheriff's Department for homeless programs. Good. They probably are doing more for homeless than other people. There are literally billions of dollars in LA County sitting on the sideline. 2.2 million is nothing. They have billions sitting there that they're going to waste on extremely expensive condominiums that are doing nothing for homeless. So I don't mind them giving the Sheriff's Department some funds so they can do things like get social workers into their squad cars to go out there and help the homelessness. All right. We have to wrap things up. We appreciate you guys being here. We'll be in here tomorrow with Tyrus and Timp. I think it'll be a really good show as well. And we'll see you then.
Always a good show.
Mm-hmm.